Hello, everyone. My name is Rebecca Kale. I'm presenting my capstone project, which explored the perceptions and barriers of vestibular rehab among occupational therapists and occupational therapy assistants in the Gulf South region. And this was conducted through a survey. So I wanted to just briefly explain my background as to why I wanted to do a survey. So I started in vestibular rehab in 2014. And when I went to the gold standard CEU course, it's a comprehensive 1 week competency-based course at Emory University, led by Richard Clendaniel, who is a founding provider and practitioner, and literally wrote the book on vestibular rehab with Susan Herdman. So when I was there, I noticed that out of 200 people, I was the only OT. And I was very fortunate to have the support of my employer to do this type of rehab and this specialty and really build a practice. So I spent the next 10 years developing this specialty practice area. And within a couple of years, I realized, wow, OT is really a wonderful fit for these people because it's more than just giving these clients the right exercises or the right positioning maneuvers. It's also about adapting their occupations and their meaningful tasks so that they don't avoid those things and fall further into anxiety and depression. So as OTs, we're such a good fit to kind of blend those two areas of practice. So I started taking students and really developing a practice in the Southeast Louisiana region, and those students went on to work in vestibular rehab. So I have about 8 or so practitioners in this general region. So I didn't want to survey such a local region. I wanted to branch out a little bit. And I really needed to, when I transitioned to academia and I started my scholarship journey, I knew my perception of vestibular rehab and I thought it was within our scope of practice and that we should be doing it. But in order to make an appeal to maybe ACOT and accreditation standards, I wanted to get the opinions of as many OTs and OTAs as I could. So that's why I did the survey as a kind of a jumping off point to start my research journey. So as a brief introduction, the purpose of this capstone was really to highlight the importance of our role in vestibular rehab, or VR, and determine the perceived level of competence and confidence in evaluating and treating clients with vestibular impairments in the Gulf South region. The goal of this survey based research study was to identify gaps in knowledge and training, explore barriers to implementing VR, and advocate for the greater inclusion for OTs and OTAs. Given the prevalence of vestibular disorders affecting approximately 15 to 20% of adults each year, it is crucial that OTs are equipped to address the issue as part of their clinical practice, especially with the older adult and the falls risk, which is not highlighted on this poster, but it's a big component of my manuscript. So vestibular dysfunction often leads to dizziness, imbalance, and significant reduction in quality of life. In fact, about a third of adults in the US suffer from vestibular hypofunction, which impacts daily activities such as leaving the home, performing self-care, and engaging in leisure tasks. For these individuals, vestibular rehab can significantly improve their symptoms, reduce their falls risk, and enhance their ability to engage in daily activities. However, despite the proven benefits of VR, there is a noticeable gap in the literature. OTs are virtually non-existent in the literature. So when I started on this journey, there was only one name that kept coming up, Dr. Helen Cohen, who was affiliated with Baylor's Medical University, but she was an OT, but she's since retired. So I literally Googled her and cold called her, emailed her. Now she's a mentor who has been very helpful with this process. And I'm hoping to continue our relationship going forward. For example, later on in the literature review, she's one of the only ones that have been published. So she actually published the AOTA's recommendation for VR, and I'm going to help her edit the next one. So that's been really cool. So let me jump back, sorry. But OTs are virtually non-existent. And that's what I'm trying to change. And this is how I'm hoping to start telling this story. So the American Physical Therapy Association has a clinical practice guideline for VR, for vestibular hypofunction. They explain in exact detail the diagnoses, how to evaluate the diagnoses, how to intervene with specific exercises, including frequency, duration. However, their clinical practice guideline does not provide recommendations for occupational-based interventions or modifications. We can all appreciate the importance of access and performance of functional and meaningful tasks for an individual's overall well-being and recovery, and the deficits that would arise if a client is not able to participate in the activities that they enjoy. So again, AOTA, through Helen Cohen, has provided an expert recommendation for vestibular rehab. However, it is not meant for entry-level practice. This expert opinion classifies vestibular rehab as an advanced skill and does not offer support for entry-level practice or education initiatives for exposure to this practice area. So if OTs and OTAs go through their curriculum and they're not even aware that this is even an area of rehab that exists, then they wouldn't take the CEUs and they wouldn't get the practice in order to help their people. So anecdotal evidence and really the overall hypothesis of my research indicates that OTs may not feel adequately trained or confident in treating vestibular dysfunction, and that VR is often underutilized in OT and OTA and therefore not represented in the literature. So to better understand this issue, I designed a survey consisting of 11 anonymous questions utilizing a mixed method design. Some Likert scale questions, some select all the apply questions, and one open-ended question. So I wanted to gauge the level of comfort and knowledge of current OT and OTAs when addressing and practicing VR techniques. SurveyMonkey was used as the platform to create and analyze this survey. So my survey questions are included in table 1. We will go through those in a brief second, and I'll also kind of talk about the results as we go through the questions. So I did go through the IRB process through Marymount, and this was approved IRB 1210 on October 30th of 2024. The inclusion criteria for the survey participants included informed consent, 18 years of age or older, able to read and write in English, currently employed full-time at least 32 hours a week as an OT and OTA, and current residents in the Gulf South region. So Texas, Louisiana, Mississippi, Alabama, or Florida. Participants were recruited through convenient sampling through emails distributed with a link to the survey. A total of 532 participants were recruited through the Louisiana State University Health Sciences Center, New Orleans, CORE, Experiential Learning Management System. So this is basically our clinical affiliation platform. So again, we do have clinical affiliations all over the country, but a wide concentration in the Gulf South region. So I wanted to expand from Louisiana, but I didn't feel like I would have enough on the national level. I felt like the Gulf South was the way to go. So I went through this program and I deselected any OT or OTA emails that were not in the Gulf South region. So I ended up sending this email out to 532 participants. So included in the email was the recruitment, just describing the study, and also going through informed consent and with a link to the survey. And also included all the inclusion criteria. Okay. And again, SurveyMonkey was used to analyze the quantitative, descriptive statistical data, and thematic data was analyzed to create and describe common themes among open-ended responses, and that was done by me, the principal investigator. Okay, so now I want to go through the survey questions, which is in table 1, and I will highlight some key findings in the results section and the two figures that I have here, figure 4 and figure 5. So I was very pleased that I had 79 responses to analyze. The findings strongly support my hypothesis that OT practitioners in the Gulf South region are not adequately trained in VR and are therefore not routinely incorporating this into their practice. So I want to discuss some of the key results. So questions 1, 2, 3 were more about demographics. Question 1 asked, about length of experience. How long have you been practicing as an OT and OTA? And I was pleasantly surprised to get a wide range of experience. So 25 participants reported that they've been practicing more than 20 years. 18 participants have been practicing 6 to 10. 17 have been practicing 1 to 5. And 14 have been practicing 11 to 19. The next question asked about the primary setting that the participants work in. The three most prominent settings reported included 28 participants reported outpatient rehab, 20 reported pediatrics, and 19 reported acute care. And the third question asked about what age ranges do you predominantly treat? And the age groups representing population serviced included 27 participants reported that they see patients within the 41 to 64 age range. 25 participants reported that they see adults over the age of 65, and 21 participants work in pediatrics, and they said that their age range is less than 13. Question 4 asked about what is your attitude towards the following statements? And this was on a Likert scale. The statements were falls and falls prevention is a significant part of your practice, and dizziness and or vertigo are symptoms reported in your practice. So the majority of participants, including 29, agreed that falls and falls prevention were a primary complaint seen in their practice. And the majority of 25 participants reported clients experiencing dizziness and vertigo seen in their practice. And question 5 was a yes or no question asking, have you received formal training in vestibular rehab? So the majority of participants, being 50, responded no. And the remaining 29 participants responded yes. The participants who responded yes to question number 5 were prompted to complete questions 6, 7, and 8, because it's more detailed questions that I wanted to get more information about what types of treatments they were doing. And then everyone jumped back in at question 9. Okay. So question 6 was, how often do you incorporate vestibular techniques in your practice? So only 29 participants again answered 6, 7, and 8. And I had a lot of mixed reviews on this one. Some of the options were daily, very frequently, rarely, or never. And that was kind of equal across the board. So I want to eventually do a follow-up, question about, okay, well, if you receive the education, why aren't you implementing it into practice? So something I'm going to include in my discussion of my manuscript. Okay, question 7. Which vestibular rehab techniques do you utilize? Select all that apply. So some of the techniques that are traditionally used are oculomotor assessments and interventions, static and dynamic balance, functional gait, repositioning, for positional vertigo assessments and intervention, and also just functional habituation. So I wanted to get some information about what techniques are routinely used. And question 8, what is your opinion on the following statements? Vestibular rehab helps to reduce falls, reduce symptoms of dizziness, and improve function. So I wanted to get their perception how effective they thought VR was. And this was a Likert scale question, and ranging from strongly agree to strongly disagree. So the 29 participants who did receive the education, 20 to 23 participants strongly agreed with the statements that I just stated in question 8. Now everyone jumped back in on question 9, which is highlighted in figure 4, which asked the participants, what do you perceive are the primary barriers to implementing vestibular rehab in your practice, and select all that apply. So 50 participants reported lack of training and knowledge as the primary barrier, followed by 30 participants saying low patient demand. And then the other option, they reported that some of them were primarily hand therapists. So this was not really in their purview. 24 participants stated lack of resources and equipment, and 18 participants stated limited time during sessions. So overwhelmingly, it was the lack of training and knowledge that jumped out for this one that was most important. And then in that other option, a couple of participants filled that out. That was optional. One participant stated that physical therapists typically treat these diagnoses in my clinic as they are seen as the experts, while another emphasized that medical doctors don't know that OTs can effectively evaluate patients for vestibulopathy as an additional perceived barrier to VR implementation. And question 10, which is highlighted over here in figure 5, ask participants to share their opinion using a 5-point Likert scale, ranging from strongly agree to strongly disagree, asking them about educational supports for VR within entry-level curriculums in associate or graduate programs, also postgraduate CEUs. So figure 5 demonstrates the majority of participants, or 40 participants, strongly agreed that VR is within OT and OTA scope of practice. Most participants, 25, disagree that the OT and OTA curriculum support knowledge of vestibular diagnoses. And the majority, again, being 26, also disagree that OT and OTA curriculum support competence in vestibular evaluation and intervention. And the majority of participants, 29, felt neutral about adequate CEU offerings to OT and OTAs regarding VR. The 11th question was open-ended and allowed participants to provide additional comments regarding vestibular rehab. Responses indicated that there are barriers to providing VR, including overlapping scope of practices between OT and PT and lack of exposure in the OT and OTA curriculum. One participant noted specific barriers to providing these specialized services, including lack of physician or provider education, lack of public awareness that vertigo can be treated, and lack of institutional support. And again, several participants mentioned the need for education in entry-level curriculums. So in conclusion, the study sought to determine the competence and competence of OT and OTA practitioners in the Gulf South region. Most perceive that it is within our scope of practice to do this, and most see the gap in the education and the knowledge access. And the survey respondents also supported the researchers' hypothesis that VR, again, is within the scope of practice and that it would help to address the falls risks and the symptoms of dizziness while supporting the overall function of our clients. So as a call to action, I really want to advocate for the expansion in the curriculum to add this in entry-level OT and OTA programs, just as an exposure to get started, because if that awareness is not there, then the specialty will never grow. By doing so, we can ensure that we are meeting the needs of our clients to treat dizziness, imbalance, and other symptoms that are impacting their quality of life. So my next plan is to do a national OT and OTA survey of the schools to see if this is included in their program, and if so, which classes. What is their perception? Do they think that this needs to be in an entry-level curriculum? So I want to kind of gauge that information before I attempt to appeal to the ACODE standards to get this in some way on our curriculums. Because OTs, we learn and can do hard things. We have specialty knowledge in anatomy, physiology, activity analysis, activity modification, and especially in the realm of falls prevention for our older adults. This really needs to be included. And OTs may struggle to realize their full potential in this specialty if they never have awareness or acknowledgement of their role in this area. So acknowledgements, I just want to send a shout out to Dr. Siebla, who is my capstone mentor for helping me with this process and the IRB process. My LSU HSC New Orleans colleagues, Dr. Helen Cohen, Marymount University and the IRB support, and all my dizzy clients who suffer in silence and often appear normal, although they are far from it. This is for you. So thank you for your attention. I look forward to any questions that you may have. If you want to discuss this further, if you're interested, please email me directly. And thank you very much for your time.